And my goal for this presentation is to enhance understanding of CKD as a global public health burden and raise awareness about kidney transplants as the optimal treatment modalities for kidney failure, and share the Rwanda experience about the transplant that is being conducted, and then stimulate discussion. And as introduction, as you may know, CKD is a public health concern, and this is from the 78th World Health Assembly that was conducted in 2025. The WHO recognized CKD as a global public health priority, and is now recommended to all countries, all government to emphasize on kidney health and CKD management, because now majority of patients are suffering from CKD worldwide, and so they recommend to be a health priority and to emphasize on insurance coverage on kidney disease management, because more than 850 million people worldwide have CKD, like 1 in 10 adult people suffer from kidney disease at any degree. And it is higher than the number of diabetic worldwide, 2 times higher, and it is 20 times higher the number of patients suffering from cancer or from HIV disease. So as you can imagine, this is a big burden. And each year, around 10 million people need dialysis or kidney transplant. So it is a heavy financial burden, especially in low-income countries, because 95% of patients with kidney failure in low-income countries can't afford either dialysis or kidney transplant. And they are now among the 10 leading causes of death. It doesn't mean that CKD will conduct people to death when they have kidney failure, but also even before kidney failure, it's a high risk of mortality. Like more than 1.5 million deaths attributed to CKD worldwide. So starting for us, I assume everyone has a normal kidney function, so we are recommended to use those preventive measures to protect our kidney. So there are 8 golden rules that are recommended from by the ISN, and they are like, we have to keep being active and drink enough water, especially when you are in a hot climate, and also check and control the blood pressure and the blood sugar, because they are high risk, they are the most predictor of CKD. We should avoid smoking and avoid over-the-counter medication, especially the non-inflammatory drug, and also check your kidney function, especially when you are at risk of developing kidney disease. By definition, CKD is an abnormality of kidney structure or kidney function which persists for more than 3 months and has an implication to health, because you may have a normal kidney function, but if the kidney structure is not normal, you are considered as having CKD. GFR and urine protein or albuminuria are independent predictors of mortality risk in patients with CKD. Proteinuria have shown to predict people to have cardiovascular disease and also predisposed to progression to kidney failure. And so this image is showing the heat map that was recommended by the ISN, just to track those people who are at high risk of developing kidney failure or having cardiovascular risk or other complications associated to CKD. As you may see, you may have a normal GFR or a GFR around 60, but if the proteinuria is significant, above 300 milligram, you are at risk of progressing to kidney failure or cardiovascular mortality. And from this, those are the common risk factors of developing CKD and also progressing. Mainly, we're talking about albuminuria or GFR, but those diseases that predispose people to have CKD also, they predispose them to fail. And especially we have hypertension and diabetes as the common one. Also came the cardiovascular disease, dyslipidemia, smoking, obesity, and other metabolic syndrome, and nephrotoxic drugs. They don't include glomerular disease because a small proportion of population have glomerular disease, but if they have proteinuria or significant proteinuria, also they progress to kidney failure. And again, those initiating factors, plus the age or the sex and the socioeconomic status, will predispose people to have to progress to kidney failure or to die from CKD. So a lot of studies have been conducted to assess, to see if, like, way that can be done to reduce the progression to kidney failure. And this is a summary of most of them. Most of them have been conducted on diabetic patients, but they are proven medication that can be done, can be used on non-diabetic patients, especially when they have proteinuria. And as you can see, we have mostly the renin-angiotensin system inhibitors. They are the #1 protective, kidney protective drugs, and they have to be used in anyone with proteinuria. And again came the SGLT2 inhibitors that can be used either in diabetic and even non-diabetic patients. And they have proven to reduce the progression of kidney failure, but also protect the cardiovascular events. And also came the non-steroid domineralocorticoid receptor antagonist, the finerenone, that was introduced in 2022, but also it helps in diabetic patients to reduce the progression of kidney failure. And again, the GLP-1 agonists that are used for diabetes and also for obese patients, they also they are kidney protective, like they reduce proteinuria and reduce the progression to have kidney failure. Unfortunately, all patients, even if we do prevention or we give those medications to reduce the progression, but some of the patients will end up by having kidney failure. And if they have kidney failure, they have to be also treated by either transplant, dialysis. There's now conservative kidney care, which is the management and non-dialysis and non-transplant management of patients with kidney failure, especially those who have a short life expectancy. It's a medical management and supportive care that is approved also to be among the kidney replacement therapy. So comparing dialysis and transplant, I think everyone knows the transplant is better than dialysis. Of course, those both has side effects, but the transplant is better than dialysis in terms of life expectancy, because the 5-year survival on dialysis is only 40%, and it goes up to 90% when the patient receives a transplant. And the quality of life also is better with transplant than dialysis. Because dialysis has a big treatment burden, so they spend 4 hours in the hospital 3 times a week, and there's a lot of side effects associated with dialysis, including persistent fatigue and catheter or dialysis access complications, and also they have lifestyle limitation because they have a restricted diet, which is a big burden to the patient. Of course, transplant has also its own side effects, including being on long-term immunosuppressant drugs that predispose people to have infection and malignancy. Some of the cancers prevalence increasing with transplant, and the risk of rejection that is always there, and the patient has to be cautious with that. And sometimes the patient post-transplant, they can fail and go back to dialysis. The cost, there's a big cost burden with dialysis, because dialysis is intense, like it's cost intensive over the years, because the patient, each session of dialysis is paid, each complications associated with dialysis is paid, and the cost is too high. Considering, like comparing to transplant, that the cost may be higher initially when they get surgery and the post-transplant, few months post-transplant, but it is cost effective compared to dialysis. And when we talk on protecting the planet, dialysis has a big burden on the environment, because with dialysis we use a huge amount of water, energy. There's plastics that are being used with dialysis, and to generate gas emission. And this is an example of how much carbon that one session of dialysis took. It takes almost a big amount of carbon as a car driving 240 kilometers. So this is a big pollution to the planet, and I think like we should emphasize on having transplant than pushing people to dialysis. So this is what I was saying, kidney disease and climate change, they worsen each other. Dialysis worsen the climate, but also when climate can affect people, can predispose people to have end-stage renal disease and end up on dialysis. So the cost of treatment is not always highlighted, but if we emphasize on prevention and delaying progression, it will be cheaper than putting people on dialysis or doing transplant. That's what I mean. Like we have to emphasize on preventive measures and at least treat to delay the progression, which is cheaper. And again, that transplant is way cheaper than being on dialysis. So quickly talking about kidney transplant. So this is a question that most of patients ask: if I get a transplant, are you going to remove my kidney, my other kidneys? So their other kidney are not removed unless there is an indication to remove them. So the transplanted kidney is usually implanted on the iliac fossa, any side, right or left, but the other kidneys are stay there unless there's indication to remove them. So as we've been talking, transplant is the best treatment of choice for kidney failure because it is to improve the quality of life. It is cost-effective, and it is a life-saving and prevent some of the cardiovascular events associated with dialysis or kidney failure. One kidney is needed to keep the patient alive. That's why when someone donates a kidney, it remains alive also. So one kidney is enough for the patient. And the kidney can come from a living donor or deceased donor. Here we only do living, but in other countries, especially developed countries, they can do deceased donor kidney transplant. And the success rate depend on the types of the donor, but it goes up to 98%. So the mean is between 90 to 95% the first year, even after 5 years. And the survival will go down progressively according to the patient and other risk factors. The graft can function up to 20 years or more. And some of the patients, they have it even up to 30 years. But the mean that majority of patients have a graft function up to 20 years. Preemptive transplant, which is transplant before starting dialysis, is better because it avoids those patients the complications associated with dialysis, but also it was shown to improve the outcome, the survival rate, reduced complications, even cardiovascular complication. So transplant is the most widely, kidney transplant is the most widely organ transplanted worldwide if you compare other organ transplants. And the number keep increasing because also the number of CKD patients increase and the number of transplant program also increase. There is still a challenge of the shortage or access of donated kidney. And this makes patients to be on long waiting list. And sometimes there is organ trafficking, as you may probably, organ trafficking, transplant commercialism, and transplant tourism, which is not acceptable, but unfortunately that is what is being done. So as a quick history of kidney transplant, the first successful transplant happened in 1954. Between identical twins. This has been tried, transplant has been tried starting from the skin to see if they can give a graft and to survive. But unfortunately, those trials also failed. Most of them failed because of rejection. This was the first successful one in 1954 between twins. And later on, when they kept doing the transplant, every time they tried, there were rejection. But with the researchers, they discovered the human leukocyte antigen and the antibodies that they were the one that's driving the rejection. And also they discovered this complement-dependent cytotoxicity cross-matching, which is the way to detect antibodies before you do the transplant, and you can predict a patient if can have rejection or not. After this, then they started having some success with giving those patients who are sensitized, giving them some of the to reduce those antibodies by radiation or steroid, but it was not enough. Still, the survival rate was very low. And in the 70s, they discovered the first drug, azathioprine, which is one of the immunosuppressant drugs that we're using. And with this, the survival rate of transplant patients increased up to 50%. But again, the rejection rate was higher because the azathioprine alone with steroid was not enough. And they kept searching, and in 80s, they discovered the cyclosporine that can help because they're looking on the physiology of the immune response and how the body reacts when they receive a kidney. They found that cyclosporine, which is a calcineurin inhibitor, could help in improving the survival rate of transplant patients, and it increased the survival rate up to to 80%. And again, from this, they discovered other medications, including tacrolimus and the medication that are used in induction therapy. And for now, the survival rate with those medications that we are using is above 90%. So that's a quick history, and maybe with the surgery also there has been advances, they are improving, and now they can do laparoscopy or robotic transplant. All those make the survival rate of transplant higher. So talking about the survival is because mainly the most reason of failing a kidney graft is the rejection. So what happened with our system is like there's protein that are designed to protect ourselves from foreigners. So those proteins are called major histocompatibility complex, which is a group of genes that are called cell surface protein, and they are responsible for presenting antigen to T lymphocyte. There are two classes, and the human, they are called human leukocyte antigen. We have class 1, which is present in all nucleated cells, and they present the CD8 T cells, and class 2, which are present on antigen-presenting cells. And this allocognition is like the ability of the immune system to recognize a non-self protein and to trigger the immune response. So this, when we are doing immunology workup, that's what we are doing. We are just typing or looking on which HLA types that the donor and the recipient have to see if they can match together, or if what is the degree of mismatch, and also check if there is any preformed antibodies that the body could recognize as non-self when we do the transplant. So the immune response can be summarized on this figure. Like when you get a kidney or any other organ, the organ, of course, on the cell surface, there's those antigen, the HLA antigen, that determine anyone. And then, so the recipient, antigen-presenting cell, we took those protein and present to T cell to just verify if this is acceptable to me, or if it is not mine, I will reject them. And once they are presented to the T cells, because the T cells will recognize those HLA as non-self, so they start the co-stimulation signal, which is a production of molecule that will enhance the receptors, and they will feel like just a cascade of reaction to activate the T lymphocyte to protect themselves against these foreign cells that are coming. And then with this cascade of reaction, there's a T cell activation and cell proliferation. With this T cell proliferation, the patient starts having what is called cellular rejection, because those T cells start to attack the graft. And also there's activation of B lymphocyte, which come later, but the B lymphocyte will produce antibodies to fight against those antigen. And when you have antigen-antibody complex, it activates the complement cascade, and the complement cascade will activate the inflammation process, and we have antibody-mediated rejection that makes the graft to fail. So if nothing is done, if anyone who receives a kidney, this is what will happen, unless they are identical twin. Otherwise, this will happen, and the graft will just die in a few weeks after this. All those processes happening. So to prevent this, we do the pre-transplant evaluation, and among the evaluation is in different steps, but the evaluation is recommended to all CKD patients who are stage 4 or 5, and they are expected to progress to kidney failure. You can predict the progression using the albuminuria and the GFR. There are calculators that are now available to predict the kidney failure in 5 years or 10 years, and those patients that you feel that they will progress to kidney failure, you can start to prepare them on kidney transplant so that they get a preemptive transplant. So the aim of the evaluation is to detect and treat coexisting illness, because not all CKD patients will we have a transplant because they are contraindication to transplant. So the aim is to detect those conditions that can make them not eligible to transplant and treat them if possible. And they just to limit the risk of, to increase the survival rate after transplant. Also to evaluate the cause of CKD because there are diseases that recur after transplant and they have to be either stabilized or like you need education with the transplant, and sometimes you avoid the relative donor transplant because it can increase the risk of recurrence. So we have to assess the immunology compatibility of the donor and the recipient. And again, we assess the general health and surgical risk of the donor, because this is mandatory to, of course, we need a kidney, but we need that donor to remain healthy and survive longer. So we check the general health and the surgical risk of the donor, and we screen conditions that may predict complications from having a single kidney in the future. And we determine if there are diseases that may be transmitted from the donor to the recipient also. So the evaluation is always adapted to the local guideline. Each center has its own guideline. For us, we have a national living donor guideline that we are referring to when we are doing the evaluation. So the evaluation usually starts by the nursing coordinator. There's a nurse coordinator of transplant. When they receive a couple, a donor and the recipient, what they do is just they educate those payers about what is transplant. They explain them the process, the complications associated with transplant or donation, and then they have to do registration process and the informed consent form to be signed. Then they are sent to the psychologist or the psychiatrist, because the psychologist will assess. For the donor, they will evaluate their willingness, what motivates them to donate, and if they are conscious of what is the process and the post-donation outcome. And also they assess for the recipient, they have to assess if there is any psychiatric or psychological condition that can affect the outcome of the transplant, and they assess if there is any substance abuse, because all this will make a patient to be non-adherent to the transplant. And after the psychosocial evaluation, they are seen by a nephrologist. The nephrologist has to look on the cause of CKD, if the risk of recurrence, see if there's any other associated condition that has to be treated or stabilized, see if the patient is compatible with the donor, and again, decide whether the patient is eligible for transplant or not, and see the complications associated with chronic kidney disease. So for the immunology, we first check the blood group. They have to be of blood group compatible. And then we check if there's any sensitization event, meaning the patient has been predisposed to things that make his body to produce antibodies, being transfusion, pregnancy, or previous transplant. And I would emphasize on this for those patients, CKD patients, because they are always anemic. It's better to avoid transfusion as much as we can, because we are planning for them the transplant in the future. So better to avoid transfusion as much as we can by treating anemia by other measures and preventing them to have the symptomatic anemia. And in immunology also, we have to check this HLA typing we're talking about, and again, check if there's any preformed antibodies that can make the patient to reject their kidney. For the surgical evaluation, the surgeon will evaluate both the donor and the recipient. For the donor, they just assess the anatomy to see how is the kidney, where is the location of the kidney, is it easy to do nephrectomy on that, and decide on a type of surgery they will do. And for the recipient, they have to check if the vessels are patent, if there's any obstructive uropathy that has to be solved before, if there's any coagulopathy or obesity. So they do the full surgical evaluation to improve the outcome post-surgery. And as per the World Health Organization, because it is illegal to sell or buy an organ, so there are regulations driving each transplant center. For us, the transplant is driven by the constitutional law that was published in March 2023, and those patients has to pass through the National Transplant Committee to assess if everything was done in order, so that there's no litigation after they donate the kidney, either for the recipient and for the donor. So this is a list of contraindications to kidney transplant. Some can be corrected and the patient will get a transplant. Others, if they are irreversible, they are absolute contraindication to transplant. So any patient or any condition that make the life expectancy less than 2 years is a contraindication to kidney transplant, because there is no, what we are expecting with transplant is a long-term outcome, and there's no need of doing all the process in someone with a short life expectancy. And as you can see, end organ damage is a contraindication, except for cirrhosis, because in centers that are able can do concomitant liver and kidney transplant together, and the patient improve on both sides. For the infection, of course, if there's active infection, they should be treated first, except for hepatitis C that has a guideline that can be treated after the transplant, but other active infection should be treated before the patient goes to transplant, because as we see, if the patient gets a transplant, he will be on high-dose immunosuppressant drugs, and we have to prevent the infection to reactivate. So for the donor, what we do during the evaluation, we check the risk pre-donation risk of the patient to risk of mortality, but also risk of developing kidney disease in the future. And we check the risk isolated to the donation and the risk associated with donation. So if the donor already has a family history of kidney disease, or has, for example, hypertension or prediabetes, they are exposed to develop kidney disease in the future. So they shouldn't be they shouldn't donate. If there is other risk that we may predict after donating the kidney, also they should be excluded. So you just weigh the risk pre and post donation before deciding on or accepting a donor to donate his kidney. So the recurrence risk post donation, it depends on the type of the diseases, especially the genetic diseases are the most common one to recur after transplant, especially the glomerular disease. And as you can see, this is the percentage of risk of recurrence after the transplant. If you look on diabetic, the risk of recurrence is 100%, but it doesn't mean that if the patient develop diabetic kidney disease, we have graft failure or graft dysfunction. By histology, for any diabetic patient, if you take a biopsy on the graft, there will be sign of diabetic kidney disease, but doesn't affect the graft function or the graft survival. That's for diabetic, but for focal segmental glomerulosclerosis, if the patient has recurrence on biopsy, also the risk of graft dysfunction and again failing the graft is higher. So the risk is, of course, is there, but it depends on which kind of disease and who is the donor and the overall patient. So it doesn't mean that if the patient has diabetes, we develop after the transplant, we develop again CKD, because you know how long the diabetes take to a patient to develop CKD. It's like in terms of 10 to 20 years. That's the same for the graft. So also this, we have to take them into consideration, because there are diseases that if you know the patient has such disease, for example, if they have membranous proliferative GN, or if they have dense deposition disease, the risk of recurrence and failing the graft is too high, and then they are recommended to avoid at least living donor. For deceased donor, they can receive it, but for living donor, it's advisable to think twice. And the problem we're having here is most of the patients, we are seeing them at late stage, they are already on dialysis or they have kidney failure, and you can't know what was the cause of CKD. So after the evaluation, so the patient is scheduled for surgery. So the surgeries is a parallel surgery. They do nephrectomy, and then in the other room, they will do the transplant. So for the nephrectomy, there are different techniques that I will not go in detail. They can do open nephrectomy or laparoscopic and even robotic, but the better the one that make the patient, the donor, to be to be safe, the surgery that is safe to the donor, and like usually for the donor, they are discharged in the following day, and they can go back to their usual activities within 3 to 6 weeks. For the transplant, when they do nephrectomy, the graft has to be preserved in a cold storage the time they are preparing the transplant. And this time between the removal of the kidney and the implantation, this determines also the survival or the function, the function of the graft. Because if the graft is removed and just stay in a warm environment, and it is not stored in cold, this will make some of ischemia on the graft and can make the graft not to functioning immediately after the transplant. So it's usually immediately stored in the cold, and then it can, before the transplant. So if you ask how long can the organ stay in the cold, especially the kidney, can stay alive until they do the transplant, the maximum from the books is usually 30 hours, but this will depend if it stays longer, the risk of not functioning longer also goes higher. So it's better you do the nephrectomy while the transplant is ready to get to be anastomosed to the transplant patient. The procedure is usually done, as we said, in the iliac fossa, and the anastomosis is from the graft renal vein to the iliac vein, and the renal artery to the external or internal iliac artery, and the ureter is anastomosed to the bladder. There are complications associated with the surgery, including the infection or dehiscence. There are vascular complications which are bothering us, because if the patient develops renal artery stenosis or renal vein stenosis or thrombosis, the graft, more than 50% will not function, and that's need immediate rerook, and it's possible remove the thrombus as quick as possible. They may develop penephric collection. I think for those who rotate in nephrology, you see most patients with penephric fluid collection. This we are able to manage them, and the graft survive, but sometimes they are associated also with fatal complication. Other complications include urinary leak or ureteral obstruction. Those are the immediate or early complications associated with kidney transplant surgery. To prevent the rejection, those patients who get the transplant surgery should be on immunosuppressant drugs. There's now, after the history that I shared, there's a long list of immunosuppressant drugs that can be used. One are used as induction, meaning they're used before they do the anastomosis or they do the transplant to prevent against early rejection, assuming that there are antibodies that are performed that we couldn't detect before when we do evaluation. So to prevent those rejection that can come from those performed antibodies, we give them induction immunosuppressant drugs. They are of different classes depending on the risk of the patient. If the patient is at high risk of rejection, we give lymphocyte depleting agents, which are like thymoglobulin. If the patient is low risk, we give monoclonal antibodies. The one we usually use is this basilicimab. All medication have side effects that we have to look into, and because they have also drug interaction with others, we have to check on that cautiously. Usually for the induction therapy, we use high-dose steroid and either lymphocyte depleting agent or non-depleting agent molecule. After the induction, after the surgery, those patients have to be on lifelong immunosuppressant drugs. So they are pure medication, but they have to be used in combination because the mechanism of action is at different site of T-cell activation. So we usually use steroids, we use calcineurin inhibitors, and inhibitors of nucleotide synthesis together combined. The group of those classes have a lot of medication. What we usually prefer to use is a steroid like prednisolone plus one calcineurin inhibitor, either tacrolimus or cyclosporine, and we can use an antimetabolite, which is mycophenolate or myfortic, or even azathioprine for some patients. For the other drugs, like the target of rapamycin inhibitors are used long time after the patient, like after years, because they prevent the cancer proliferation, because we've seen that the patient are at risk of cancers, so they prevent cancer proliferation, but also they have other side effects. So we usually use them after years of transplant. Belatacept is sometimes used for those patients who don't tolerate tacrolimus inhibitors. Unfortunately, we don't have it, but it's just used for a small group of patients. So complications, as we were saying, there's a lot of complication depending on the age of the graft. Immediately post-transplant, the common complication is related to surgery, but also patient can have early rejection, they can have nosocomial infection, and the graft cannot function without any specific reason, maybe because of volume or drugs, so they may have like delayed graft function and nosocomial infection. And after the transplant, what we usually see those patients, they have polyuria, they may make 500 cc of urine an hour, and they have electrolyte imbalance, and sometimes if they are not, the volume is not replaced appropriately, they may develop dehydration and they have prerenal AKI. So those are the acute complications. In the first 6 months, the risk of opportunistic infection is high because they have received high dose of immunosuppressant drugs, so the risk of opportunistic infection goes higher, and they may have drug side effect associated with drug toxicity, like for CNI, they are nephrotoxic, so we usually check the trough level to know the exact dose to give. They may have cytopenia related to mycophenolate mostly, and we have to adjust the dose. And they may develop post-transplant erythrocytosis or diabetes according to the medication they are receiving. But all those, that's what we are following in the first 6 months. After 6 months, they usually have a relatively similar complication as other patients. So we have to check those drug toxicity. We check if they don't have recurrent disease, because if the disease is recurring, we see the proteinuria. We check for cardiovascular disease, and we have to check the cardiovascular risk and treat accordingly. They can develop post-transplant lymphoproliferative disorder or non-squamous cell skin cancer. And usually for the skin cancer, it comes late in 10 to 20 years, but the recommendation to check every year the skin to check if there's any incident sign of skin cancer that is happening. So those are, in summary, the complications associated with transplant. And according to the age of the graft, the management also will be different. So in immediate post-transplant, as we were saying, we're managing with immunosuppressant drugs, the fluid and electrolyte management, hypertension and hyperglycemia, and post-op management basically. In the first 3 months, they have to be on antibiotic prophylaxis because they are severely immunosuppressed. So we give them prophylaxis, mainly we give PCP prophylaxis and cytomegalovirus, and as we are in endemic area, we give TB prophylaxis. And also fungal infection prophylaxis. And then we have to detect early, like we do regular follow-up to check if there's no sign of rejection or drug toxicity to be managed. And then we have to emphasize on patient adherence to medication. In the long-term follow-up, so we have just to try to maintain immunosuppressant in a way they don't cause severe immunosuppression, but also they don't predispose the patient to rejection. And again, we have to screen for those chronic complications associated with transplant. So for the outcome, as we say, the survival rate at 1 year is around 98%, up to 90% after 5 years, and it goes to 75% after 10 years. And this will depend on, of course, the patient's risk also. So the common cause of death in transplant patients is not graft failure, it's cardiovascular disease. And as we're saying, they can have the graft for 20 years or more. I had one patient who was having the graft for 27 years, so even here it is possible. So transplant patients may need multiple transplants in their lifetime, especially if they are kids, because if they get the transplant at a young age, the graft may fail later, and they may need another transplant. They are reported 2 to 4 transplants in the lifetime of some patients, and it can go above 4 transplants. And the survival rate, as I was saying, depends on the source of the graft, the recipient and donor age and comorbid condition, and the degree of immunosuppression. So this was a report from Australia. They just tracked all patients who get a transplant. And as you can see, for the graft survival, it can reach up like to 25 at 30 years. And sometimes the patient survival goes higher than the graft survival, because even if they fail the graft, they either survive on dialysis or they get a second transplant. So the patient survival is higher than the graft survival. For the donor outcome, so for the living donor is safe if the patient is carefully selected. If they went through a complete evaluation and they are carefully selected, the living donation is safe. Of course, the mortality associated with surgery is around 0.03%. In most donor return to normal activities, as we were saying, within weeks. There's a small increase in long-term risk of having CKD or preeclampsia or hypertension and some metabolic disease like gout. This from studies that have been following the donor. Those are some of the complications they were finding in patients who have donated the kidney. But if it is a well-prepared donor, have shown to have a better quality of life than before donation, and they have low rate of donor-related regret. So this two studies. The first one was done in comparing donor and general population, and they found that the risk of having end-stage kidney disease was similar. Even the cardiovascular risk was similar, comparing the patient who donated the kidney and those who in the general population over 40 years. That was the study. But when they took those donors and compared them to another group of population that is well screened of those donors, as you may understand, because the donor are those patients who are healthy. So another study just screened other population. They compared them together, and they found that the risk of end-stage renal disease when your donated kidney goes higher because of those complications we're saying, like having one kidney is hyperfiltration, it may develop hypertension and increase the risk of CKD in their lifetime. So for the last slides of my presentation is just to give you an update on where we are here. So we don't have the exact prevalence of CKD in Rwanda, but according to different studies, if done in the hospital, the prevalence will be higher. In general population, it is around 4%, but whether it's 4% or 20%, the prevalence of CKD in Rwanda is high. And if you estimate the prevalence of end-stage kidney disease, according to the ISN, in Rwanda, it's 100 per million population have end-stage kidney disease. So the mortality associated with kidney disease is 23 per 100 population from the last publication in 2023. The first kidney donation transplant was done outside Rwanda on a patient in 1999. And he passed away last year, unfortunately, with functioning graft. He never needed dialysis over the last 27 years. And then in 2013, we had a first campaign of transplant at King Faisal, but because of different logistics issue, they couldn't progress. And we had more than 120 patients who received a kidney abroad till late 2023. And since 2023, we're doing living kidney transplant here with partnership with the University of Michigan and Ministry of Health. The insurance coverage is 90% for those who have community-based health insurance or RSSB. There's still a lot of issues, but at least they are covered and they can get the transplant here, especially those patients who couldn't afford to go abroad. So far, we have 217 candidates who are a different stage of transplant. Among them, we did a transplant on 89, so others are still waiting at different levels. Among the 89 patients who get a transplant, we lost 4 patients. 3 of them had severe sepsis, and others had graft failure, but still they are alive, 2 of them. For the transplant program now is being conducted by the local surgeon. The Michigan team is no longer coming as from January, and we have a big team with the surgeons, anesthesia, nephrologists, residents and nurses, and the pathologists who help us to detect if there's any rejection, to treat it early to prevent those rejection. The psychiatrists and psychologists and social workers and pharmacists, because that's crucial to do the transplant, but also to get the medication available, because they don't have to stop or delay the medication. And there is a National Transplant Committee that is always helpful, and King Faisal Hospital administration, they always push to get everything ready. The investigation all are done here, except the immunology that we have to send to Brussels. That's one of the reasons that the waiting time extend, because we have to wait for those tests to be done, and we have a limited number of tests to send. And the pathologists are able to detect the rejection and detect antibody-mediated or cellular rejection, because the treatment is different, or detect if there is a recurrent disease, and also the pharmacy. So according to studies done on our patient, the first one is a short-term outcome of patient that had the transplant here. It was done while we had 64 patients, and they followed them over 1.5 years. So the survival rate was 94% after 1.5 years. And in long-term outcome, this study was published recently, I think in January, on patients who received the kidney abroad and who are followed here. And the survival rate after 1 year was 97%, and after 5 years it was 71%, and at 10 years is 61%. So they just assessed up to 200 months follow-up. Yeah, so the challenges we're still having are about the insurance. All insurance doesn't cover transplant, only RSSB covers, and there are some of the procedures that they don't cover also, because some of them are also expensive, so we have a limited package to cover. Of course, most of dialysis patients, they don't have donors. That's the main problem, and the medication availability in other referral hospitals, because King Faisal alone can't cover all those patients. So the future perspective is to expand the kidney transplant access, to have kidney transplant registry. The surgeons are now starting to do laparoscopic nephrectomy, and we are hoping to get immunology lab here, so that it helps also for other organ transplant, because I think for GI they're planning to do liver transplant, and there's a plan for stem cell transplant, so we need an immunology lab here. And so the recommendation from our team is to review policy that's driving the coverage, because those patients need more than just drugs for their survival, and expand medication availability, and probably expand the program, because we can't rely on living donor only, because those patients will not always get a donor. Maybe possible having a deceased donor transplant, or paid donation or donor exchange, which are other programs that have been conducted in developed countries. So thank you. This is the last slide. As a take-home message, CKD is a public health concern, so we have to make it a priority, prevent ourselves first, and then prevent others. For anyone who is proteinuric, they should be at least on RAS blockade wherever, and even in health center, they have captopril. So I think it's easy to detect albuminuria and treat with RAS blockade, and send those patients to nephrologists for better screening. As we said, preemptive transplant has better outcome than being on dialysis or get a transplant after dialysis. And again, let's protect our planet as much as we can by avoiding dialysis as much as we can. Thank you. So this is the Declaration of Istanbul published by the WHO. As we're saying, the organ transplant should be equitable, allocated within countries' jurisdiction to suitable recipient without any segregation like gender, ethnicity, religion, or financial status. So I just acknowledge all those people who contributed to this transplant program. Thank you.